Thank you all for attending and welcome to our first webinar. This is more of a conversation than anything else, but thank you. We're delighted to have over 1,200 registrants today. Many are from the Gulf, the USA, and Europe and Canada. So a special thank you to all of you for making this happen. A special thank you for also our sponsors, the Saudi Neurology Society, the Saudi Epilepsy Society, the Kuwait Psychiatric Association, and of course our main support event group, who without their support, this would not have been possible. It's my great pleasure to introduce my friend Haytham Tayyib who did his neurology in Montreal and at the MNI and McGill University, then did his fellowships in neuropsychiatry and behavioral neurology at McLean's Hospital and Mass General Hospital, followed by a fellowship in epilepsy at Brigham and Women's Hospital, all affiliated with Harvard. He has a beautiful talk about epilepsy and cognitive neurology or behavioral neurology, which I'm sure he's going to talk to us a bit about today, and maybe a whole webinar about that on a later time. Haytham currently heads the epilepsy unit and provides neuropsychiatry consults at King Abdulaziz University in Jeddah, where he's an associate professor at the Faculty of Medicine. He also leads the neuroscience research unit at the faculty and welcomes collaborative work with everyone. And indeed, we've started a GCC consortium in behavioral neurology, for which this is one of our first webinars and leads to give. I think he's the Kreplin or the Kendall in the GCC, the German neuropsychiatrists, and would love to hear a bit more about the neurophilosophy and about our event today. A few housekeeping rules. This is a 90-minute conversation with about 45 to 50 minutes of a webinar and approximately 45 minutes of discussion. The session will be recorded. We'd encourage questions and answers along the way, and there will be pauses during the seminar to interact a little bit through those questions and answers. So please use those Q&As for any questions that you may have. There will be also a voice discussion at the end where we'd expect you to raise your hand for any issues. So Dr. Haytham, without further ado, I'd hand this over to you.
Okay, thank you very, very much, Dr. Abdullah. It is a pleasure to be with you, albeit electronically, but this is the way it goes these days, apparently. It's the new norm. I am super excited. I love that you referred to this webinar series as a conversation. I am hoping that we sort of find the silver lining in the cloud of COVID-19. There's been a lot of education going on in the digital world, and it's part of our responsibility to participate. I would also reiterate our thanks to the Saudi Neurology Society, the Saudi Epilepsy Society, the Kuwait Psychiatric Association for their support for this webinar series. The neuropsychiatry and behavioral neurology is one of the, if you want to call it an orphan field. There aren't a lot of, the number of professionals in a particular geographic region is oftentimes limited. We are going to be able to do great things if we probably only if we work together and if we cultivate a community where we can help each other and complement each other's expertise. Just like Dr. Abdullah mentioned, this webinar series is hopefully going to be a longitudinal effort, a themed learning experience. We kind of also would like for it to be interactive and flexible to the needs of those who continue to be engaged with us. We really want this to be a conversation. We want the series to be an evolving creature. We'll see how it goes. And I thought the first one of these webinars ought to be a sort of a general talk that starts a discussion and a conversation. The title is sort of silly, and it's sort of designed to be attractive. I've given this talk in various forms in different settings. And I sort of, if I titled it Philosophical Aspects of Neuropsychiatry, no one would have probably, or the interest may have been a little less strong. In any case, I do hope that this is going to be an enjoyable and educational hour and a half for everybody. And I certainly look forward to learning from everybody that's around. So thank you, everybody who have decided to be generous and join us in. Here are the objectives. By the end of this webinar, hopefully, we will all be able to discuss the theoretical basis underlying neuropsychiatry and behavioral neurology, and distinguish these related but somewhat different fields, and define each one of them, describe how they can work together and complement each other. We will hopefully recognize the clinical advantages of viewing human behavior from a cerebrocentric standpoint, meaning when we think that human behavior is all dependent on the brain. And we'll talk about this in some detail. We will hopefully describe the basic anatomical organization of neurobehavioral systems in a sort of overview, because each of these systems is worthy of webinars of their own. We will give an overview of what a neurobehavioral evaluation looks like, and we'll hopefully engage in a conversation. And I have a couple of cases to discuss and stimulate the discussion later on if need be. And we can also discuss what's next. We have a few of our great colleagues who are already engaged in a discussion on WhatsApp groups, phone calls, professional circles, and conferences and so on. And I'm personally looking forward to learning from every single one of them. And I'd like to thank them for supporting us and making this happen as well. So let's get into it. One of my mentors told me that if you want to tell people something, you first tell them what you're going to tell them, and then you actually tell them, and then you tell them what you already told them. And just to guide the discussion, I'm going to adopt that approach a little bit. So here's take-home message number one. The brain is the ultimate determinant of the human mind. Meaning that perception, human perception, cognition, emotions, and behavior are all entirely dependent and ultimately dependent on what happens in the brain. And that psychological factors and social factors and whatnot, they are all dependent on how they affect the cerebral functioning and what happens in the body. And if you think that this message is sort of a given, a basic fact of today's clinical world, then I'm glad. But it is actually less clearly uniformly accepted than what one might think and hope. And it certainly wasn't always the case that it was a prevalent idea to accept. And this is where we perhaps start to go back in history. I'm not a philosopher, neither am I a historian, but it is very common to start a discussion of the nature of the human mind with a picture of this guy, Rene Descartes, who is famous for saying, saying, "I think, therefore I am." Which was more fully expressed in the way that I've written it here in the slide. I doubt, therefore I think, therefore I am. Rene Descartes started questioning the nature of reality and noted that everything we see, everything we feel, everything we perceive is dependent on our perception. and made a distinction between what happens in material world and what happens in mental life. And this led to to his perception that there are two different kinds of things in the world: non-material things and material things, non-physical things and physical things, things that we can touch and see, and things that that can't be measured easily. And he classified mental life as a non-physical entity in what came to be called Cartesian dualism, or Cartesian substance dualism. And this perception that the human mind is not dependent on the body or is extra to the body led to the perception that the mental processes are happening in a separate realm. Some call it spiritual, some call it non-physical or metaphysical. And there's a whole, it sort of opens the door for a whole host of other factors and fallacies about how human behavior and the human mind are instantiated in the real world. One common fallacy is what we call a homunculus in a man, or a man in a man, where uh, you, or each of us, what we consider as the self or I, tend to control or operate the mind. So if you're looking at something and it's reaching the occipital cortex, and you have visual processing happening, there is you that is viewing what's happening neurobiologically. And of course, that I or you is ambiguous. And even if you think that you has a brain, then inside that brain, there's another homunculus, and sort of creates a perpetual process there. So at this point, if you're still following me and you're not too bored, you might be wondering, why does it all matter? Why is it a big deal? So let's use a couple of stories to try to illustrate why this is relevant. So here's the real story, obviously modified to preserve privacy of patient, but it's a typical story that you might see in any clinic. A 38-year-old female with depression comes in with profound sadness, feelings of hopelessness, social isolation, um, all in the context of significant psychosocial stressors of discovering husband's infidelity, followed by divorce and then financial struggles. Um, and she sort of continued to get worse over the course of months, found herself sitting at home without energy, no appetite, disturbed sleep, loss of anhedonia, and loss of will to go on, and finding herself thinking that she wants to kill herself. And the question that we want to ask ourselves now is, how much do we think that she is responsible for her situation? How much is she even blameworthy for the symptoms that she's in, for the mental experience that she's going through? Here's another story. Keep that story in mind and think about this one. A 38-year-old female with obsessive compulsive disorder who gets the urge to insult the divine. And if you're from around here, you know that this is a big deal. And the question that she asked me was whether she actually wanted to insult the divine or not. Do I really want to insult the divine? Is it me trying to insult the divine? She gets these urges, feeling that she wants to utter those insults and think these thoughts. But she also identifies that she doesn't want them. So she asks me, which is it that I want? Do I want to insult the divine? Am I blameworthy for it, or am I not? And I'm hoping that as we're discussing these questions, that you're thinking about them as well. And your answer may depend on your position with regards to substance dualism. So now think about what you think of this statement. Do you think this statement is true or false? There exist forces, entities that control your thoughts, emotions, and behavior, regardless of what happens in your brain. Call it free will, or call it volition or spirit or whatever you want to call it, do you think that whatever you want to call it can supersede what happens in your brain? And if there's a brain disorder, do you think that you can overcome it simply by using those, whatever that entity is that you're thinking of? And we don't mean here to discredit any of our cultural or religious conceptions. It's a simple statement about whether or not biology has an important role or neurobiology and neuroscience has an important role, the most important role in determining one's behavior or not. And this was looked at in the literature, and the majority of people actually do identify that across cultures do identify a non-physical, a subjective component. And it's sort of intuitive that you think that I am me and I have my body and I control it, and I have my brain and I control it. And this is sort of the case in 86% of people. And this was from our one of our samples. And below, you can see how one can measure this. So you present statements like the ones that I show here. The self and soul are the primary determinants of thoughts, emotions, and behaviors. The self and soul interact with the body. There are non-material factors that may supersede brain function, and so on. And you ask people what they think about these statements. And you see that these dualistic statements were endorsed by most people. So this is sort of intuitive, and it's a universal experience. It's a strong experience as well. So does it matter? It was looked at in a couple of papers. Here's one that I'd like to refer you to. We won't have time to go through it in detail, but psychiatrists and psychologists, mental health care professionals, until this day, sometimes think of, or a proportion of us think of non-brain determined aspects of the self. And that's fine, except that it was shown that people who tend to have a dualistic conception of the human mind tend to think of people as having psychological disorders and as being blameworthy for their symptoms. So that's sort of a big deal. And you may think it's, you may wonder whether or not it impacts clinical care. We looked at this in the context of epilepsy. So epilepsy is sort of easier to accept as a brain disorder, right? So what we did was that we measured attitudes towards epilepsy, looking at whether stigma has an effect on epilepsy. We asked people questions about mind-body dualism and about their beliefs in the supernatural. And I'll present some of the data here briefly. A little more than a half of our participants believed that epilepsy may be treated with magic or sorcery. And when we looked at the determinants of this phenomenon, we found out that there's a higher proportion of dualistic thinking among people who endorse non-medical treatment. And when we did a regression analysis, we found out that mind-body dualism is the main determinant of this relationship, and that belief in the supernatural actually serves as a covariate and not as a primary determinant of thinking, having negative attitudes towards epilepsy and cultivating a stigma towards epilepsy. So this sort of happened. So after Descartes, or around the area, circa Descartes, there was a negative perception of biologizing human behavior. You can look at this painting from Rembrandt, and you can see how it depicts a dissection session so brutally and almost psychopathically with whatever scientists here standing without any emotional reaction in front of this gaping torso and a brain dissection going on. What did flourish was, subsequent to the dualistic approach, was whenever somebody had a mental problem, since mental issues were supernatural, people resorted to the supernatural to treat mental disorders. And when it didn't work out, people ended up being locked up in asylums and so on, and sort of a grim picture. And their journey to repatriate the human mind into the brain perhaps began, or an important stop in it is Paul Broca's and Carl Wernicke's work, who demonstrated that lesions, focal lesions, very focal lesions, in fact, in the left hemisphere in most people, determined how their language looked like. So Paul Broca followed his famous patient Tan and demonstrated in the autopsy that the presence of this left frontal lesion, collected a few other patients and presented it and had it discussed, and declared that we speak with our left hemisphere. Nous parlons avec l'hémisphère gauche. This sort of, this is one of the first mental capacities that sort of got repatriated. We speak, now we know where language resides in the brain. And here is perhaps neuroscience's most famous patient, Phineas Gage, holding the iron rod. You know, I sort of anticipate that most people that joined this webinar would probably recognize him and recognize the iron rod, but I'll sort of tell the story quickly. He is the roadside worker that had this iron rod fly out of the tool that he was using, pierce his skull and penetrate the top of his skull and injuring the brain throughout. Miraculously, he did recover, at least by the standards of that time. He retained motor functions, attention, language, but he was no longer the same person. His personality was completely changed. There are beautiful descriptions by Dr. Harlow, who followed him, describing how he indulged in what they used to use awesome terms back then in their histories, in what they call subhuman pleasures, and using profanities, et cetera, which were all highly uncharacteristic of him. And this sort of asserted the idea that personality and behavior are indeed brain dependent, and not just diffusely dependent on the brain, but having to do specifically with the front of the brain. And perhaps those events were the launch of behavioral neurology. So behavioral neurology flourished. We studied the brain progressively, and we understood cognitive functions in more detail. So now we know what happens in the right hemisphere, what happens in the left hemisphere. We have a perception that language is in the dominant hemisphere in most people, whereas visual processing is in the left hemisphere. Some functions like memory are also they're processed verbally on the left and non-verbally on the right. So lateralization was a concept that we established in cognitive behavioral neurology. Anterior-posteriority is another concept where the more posterior you are in the brain, you're more likely on the receiving end of perceptual stimuli, either visual or auditory or sensory. And when you are towards the anterior part of the brain, you are where the output in terms of either language or motor output or social behavior and so on. So that's another dimension of understanding of how the brain works. The third dimension is verticality, where we perceive the cortex to have what we call higher cortical functions, such as complex perception and planning and complex behavior, social behavior, whereas the basal forebrain and the basal ganglia and the brainstem are where drives and the autonomic system, motivation, survival, and obligatory control take place. So verticality is the third dimension. And behavioral neurology is proud to, along with neuropsychology, obviously, to delineate the cognition as a bunch of domains and not just one domain, not one thing. There's no intelligence per se, but it's a bunch of cognitive faculties that are dependent on each other, and some are more basic to others in a pyramid-like hierarchical organization. So cognitive behavioral neurology continued to flourish, delineated aphasia syndromes, various language disorders, memory disorders. We know what neglect is. Hopefully, each of these lines will be will get its own webinar or webinars. Behavioral neurology also studied social cognition. We also discussed the neurological underpinnings of mood and emotions and personality in our patients. And we do see cases that have cognitive and behavioral manifestations in the context of neurological disorders, stroke, epilepsy, MS, TBI, neurodegenerative disorders, and so on. And the dementias are perhaps an area where cognitive and behavioral neurologists are, we are all dementiophilic, if that's a term. And Alzheimer's disease is one of the world's biggest problems. So that's one of the things that we all are concerned about. And we all see patients with dementia and Alzheimer's disease. Autoimmune disorders are with behavioral manifestations and neuropsychiatric manifestations are also among the diseases, the disorders that are commonly seen by behavioral neurology, especially in the past decade with the identification of many of these autoimmune syndromes with behavioral manifestations and neuropsychiatric symptoms. All right, here's take-home message number 2. So I'm hoping that you remember that number 1 was that the brain, the human mind is based in the brain. Perhaps the point of focus, the second point of focus is that psychiatric disorders too are brain-based. And we could continue our historical journey, starting perhaps by this painting that I like with a bunch of famous neurologists, and at the center of which there's Jean-Martin Charcot treating a patient with hysteria, held, by the way, by Joe Babinski, famous for the Babinski sign, of course. And in the past, I sort of thought that this guy in the back here was Sigmund Freud. But upon further research, turns out that it was not Sigmund Freud, but Freud actually trained with Jean-Martin Charcot on looking at patients with hysteria and conversion disorder. And at least up to my understanding, Freud was not a dualist in his approach. In fact, one of his first major projects was what he called a project for a scientific psychology. And if you, I tried to read through it and I understood nothing, but I saw that he spoke a lot about biological aspects, neurons, energy, balance, and so on and so forth. And it was the limitation of the tools that he had, the neuroscientific tools that he had, that sort of led him to focus on the phenomenological and achieve the great achievements in psychoanalysis that we have and that continue to be important till today. But But that was a point where neurology and psychiatry sort of split, and psychiatry became focused on diseases of the mind, and neurology became focused on diseases of the brain. We have objective findings in neurology. We don't have objective findings in psychiatry. And there were great achievements that were done over the past decades. Neurochemistry, psychopharmacology, all the different types of psychotherapies, and so on. Um, and then over the past couple of decades, neuropsychiatry started to flourish with the advent and progress of, we have in neuroimaging. We were able to researchers were able to demonstrate how we can show that psychiatric symptoms actually are instantiated in the brain. So this is one of the papers, for example, that I chose, where we can show how auditory hallucinations activate Heschel's gyrus, just like normal hearing. And albeit there's also additional activations in the amygdala and other areas. So the voices that patients with schizophrenia see are now more easily conceptualized as a brain disorder and not as voices coming from outside. Here's another example in patients with social phobia, where you can show activation in the amygdala as correlates for their experiences during viewing of stressful images of social interaction. So once again, demonstrating that fear comes from specific parts of the brain. And of course, if you see patients with epilepsy, you will know that amygdalal seizures are manifest with temporal seizures. Mesial temporal seizures can manifest with sudden onset fear. Moving along, we can think about obsessive compulsive disorder. Obsessive compulsive disorder was originally, the story started with Freudian fixation in the anal phase and unconscious conflict. And then over time, we accumulated evidence that there are neurochemical abnormalities, that we see OCD-like phenomena and disorders that afflict the basal ganglia, such as Tourette syndrome, Huntington's disease, Sydenham-Choreas, and so on and so forth. And we came to view OCD not simply as a disorder with psychoanalytical underpinnings, but as a disorder of the brain's mechanisms of habit formation, where the basal ganglia selects rewarding behaviors and instantiates them and solidifies them as habits. And when this goes awry, we have OCD. And so this sort of contrasts the view of a cerebrocentric view, where you can even treat refractory OCD cases in select cases with surgery, in comparison to viewing it as a disorder that can be treated with maybe medications and with psychoanalytical Freudian psychoanalysis only. This is not to say that psychological factors or therapy are not effective, but it actually provides more credibility for these approaches. So here's an example of a paper that compared people who were treated with CBT and with citalopram for social phobia, showing that people who were treated with CBT and responded demonstrated cerebral changes. Therapy works, and it does work through the brain. So the biopsychosocial approach does hold, but the psychological aspects and the social aspects, once again, lead to their effects through brain-based mechanisms. And so today, in the current world, there's neurology, there's psychiatry. There are subspecialized neurologists that deal with neurobehavioral disorders. And from the world of psychiatry, there are subspecialist psychiatrists that call themselves neuropsychiatrists that deal with psychiatric disorders associated with brain maladies and vice versa, brain disorders associated with psychiatric conditions. Biological psychiatry, I think of it as being closely tied to neuropsychiatry, and we can sort of debate what biological psychiatry means, because all psychiatry ought to be biological in this day and age. Neuropsychology is a subspecialty in psychology where clinical psychologists train in order to be able to assess psychological functions using specialized tests that are normed in populations. Don't despair, we're nearly there, and I will hand it in less than 5 minutes, I think. This is your third and final take home. The first was that the brain is the theater of the human mind. The second was that psychiatry is also brain-based and that psychiatric disorders are brain-based. And here's the third, that the clinical approach in neuropsychiatry and behavioral neurology is integrated and has a systematic feel to it. Neurobehavioral evaluation often integrates neurological and psychiatric data and takes in account not just the history that you take from the patient or the exam that you do, the data you collect from the patient himself or herself, but you also take collateral history and psychosocial and information about the psychosocial context, all of which are of extreme importance. And hopefully in the webinar series, when we come to discuss cases and we continue to have at least some people engaged, we can sort of demonstrate how getting to know some of this information is key and important. And just like any other specialty, we have investigations. So we can order MRIs, PET scans, and there are perhaps in the dementias is where imaging is most helpful, but in other neuropsychiatric situations too specifically neuroimaging can be of help. EEGs, sleep studies, EMGs, and laboratory tests are also of help in selected patients and depending on the situation. And once again, I hope that we can demonstrate this by discussing some cases at some point. And the treatments span pharmacological, therapy, and various forms of neurobehavioral counseling, neurostimulation, and even psychosurgery. And it does follow what I like to call the neurological approach, which is thinking about every phenomenon you see in brain terms. So you see someone who's anxious, where is it happening in the brain? You see someone who's depressed, where is it happening in the brain? Where is this behavior, whatever it is that you're seeing in clinic or that the patient's describing to you, happening in the brain? And you try to localize it, just like we do with a right-sided weakness, in terms of laterality, anterior posteriority, and verticality, just like we mentioned, the 3 dimensions that we mentioned before. And you keep in mind that the brain is a network, meaning that there are different hubs in the brain that are connected to each other, and a lesion at any part in the brain or the connections that, of which may lead to similar manifestations, albeit with some differences. And after you answer where the lesion is, you start to think about what the lesion is, and that depends on how quickly the lesion developed, what the past history of the patient is, and what the risk factors of the patient are. I know that I am not necessarily revealing any great secrets of life, but I do hope that the 35 or 40 minutes that I spoke sort of provides a background for discussion, and hoping that as many people in the audience engage us. And I turn it back to Dr. Abdullah.
Thank you, Dr. Haytham. So I've got a few questions that might raise some debate. I'm wondering, there's many people that say all of the testing that you've mentioned before, like the fMRI, PET scans, cognitive testing, are all indirect measures of the brain, and you really don't know what's going on inside the brain. And so I'm wondering how you might think about that, or how you might respond to that.
I mean, I wouldn't necessarily disagree. I agree. I think, I think, I want to express that, we ought to have humility. I hope I didn't come across as asserting that we know everything. Um, there's a lot we don't know, and indeed, there's if you just take fMRI, I'm sure most people came across, or a lot of the people that are interested in the area came across the harsh critique that fMRI received in a bunch of papers over the past couple of years, showing that the very basis of fMRI on many of the fMRI studies are flawed. And once again, I'm not a neuroimaging scientist, so perhaps I'm not the best person to directly respond. But let's put these controversies aside, and let's take a case like Alzheimer's. So if you read, perhaps I'm using an example that advantages me, or advantages the argument for a biologization of the neuropsychiatric phenomena. But if you read the description of the very first case of Alzheimer's, August Detter, you will read a description of a psychiatric case. That was Alzheimer's description. He says that the first symptoms were delusions of jealousy and theft and paranoia about her husband, infidelity, or something of that nature. And, I don't want to spoil some of the cases that we have, but, there are cases of Alzheimer's disease, or say other dementias, that do not manifest with cognitive symptoms. And you get a PET scan, being an indirect measure, but still you can demonstrate that the brain is not working, and it helps. And it's the approach, I suppose. When obviously diagnosing primary psychiatric disorders has validity. I'm not saying that there's no validity. There was a lot of controversy about the DSM-5 and the research domain criteria, and the NIH and the NIMH at some point stopped funding research that's solely based on the DSM, et cetera, et cetera. But that's not the message I want to focus on. What I want to focus on is that I personally, perhaps I'll reflect back on my personal experience. I think I learned most of the medicine that I practice today from working with psychiatrists. I don't think I knew how to take history before working with psychiatrists. I recognize that in today's world, we ought to complement each other's skill sets, and so to speak. So yes, these measures are indirect, and they have shortcomings, and our mainstay of diagnosis still remains the phenomenological, behavioral, observational, criteria-based approach. But the approach itself differs. And I sort of demonstrated how, when it was shown that when people don't keep in mind that we are ultimately dealing with biological disorders, most of the time, one might stray from paths that would help patients. That was a ramble a little bit. I'm sorry.
No, I think what you're trying to say is sometimes, or what you've clearly said, apologies, is that neuropsychiatry or behavioral neurology, or neurology and psychiatry in general, are flip side of the same coins.
Yes.
And I think some of these interventions are, as you said, are indirect, but they're the best we have right now. And they are suggestive of something that correlates with the best diagnosis eventually, which is an autopsy. And
Yeah.
so we're hoping, yeah.
I mean, also, I
got
mean,
some,
if I'm allowed, Alzheimer's is also a great example for this. I removed a couple of slides there that showed how, you know, in the beginning, we defined dementia by inability to do your ADLs. And then we moved back and we coined the term MCI, also behaviorally. And then we moved back and we were able to do amyloid scans and tau scans. And then we move further back and now we're starting to address people in their at-risk stages and do the amyloid scans and tau scans to try to pick them up even before they get symptomatic. And I think some of this is happening in psychiatry as well. If you look at how bipolar disorder and psychotic disorders are sort of merging at the genetic level. You know, we published something recently on the metabolomics of schizophrenia, and there's a lot out there. It's far from coming to the clinical world, but psychiatry is certainly moving in the right direction, I think. Remaining holistically, though, I mean, I think it's awesome that psychiatry remains holistic and that Freud remains sort of alive until today.
Yes.
Yeah.
So there's a few essential questions from the participants I'd love to bring up. So people are asking about the duality, and people are saying, Dr. Jude and Najadi is asking about people who believe that their mind and belief control their mental illness are more prone to stigma, as in epilepsy. Do you think those two, that the mind and the beliefs together are produce more even of a stigma than just when you say this is a psychiatric disorder or not? And then also, go on.
No, go ahead.
And then someone was asking also about Broca and 200 years. Muhammad al-Diri was asking about 200 years after Paul Broca, we still see intellectuals in the Arab world, including medical professionals and even psychiatrists, who still believe in the Cartesian dualism. How can we solve this problem? So similar questions there.
Okay. So I think if I understood the first question correctly, it was asking whether dualistic thinking predisposes people to stigmatizing, and I think we showed this in our paper. It'd be great to, you know, I'd refer people to the paper, but it's not the first.
It's a wonderful paper. I really do think it's great. It was published last year, I think.
Yes. So we showed that actually, so people's belief in the supernatural around here is common. But we showed that in itself, belief in the supernatural, be it religiously derived or otherwise, it does not directly lead to stigma. It is the belief that that your body is controlled by an external aspect that determines this. So if you look back at our diagram, we showed that if you can, that belief in the supernatural does not, or religiosity itself does not directly lead to stigma, or is not directly associated with stigma, and it works as a mediating factor only if dualism is at play, which I think is an awesome finding, because it directs your education, because you could sort of antagonize cultural beliefs, which I think you're going to get nowhere doing that. But if you teach people more about monism, the opposite of dualism, and describe how, say, take something like epilepsy and just keep asserting and driving home the message that epilepsy, including all of its behavioral manifestations, are biological disorders, you may reach somewhere. That is still to be shown, and I think we want to plan something like that as a study. How do we reduce stigma? Because epilepsy has been around for years and years and for eons, and stigma, and it has improved, and work. The Saudi Epilepsy Society over the past years has done significant work, for example, in Saudi Arabia, and we have shown that stigma has reduced to a certain extent, but like I said, more than a half of my sample uh, believed in treating epilepsy with magic and sorcery and stuff like that in the 21st century. So these are just some thoughts, and we know what we know, and we don't know what we don't know. Um, and I think dualism is not just a local experience; it's a universal experience. And what can be said here is can be said about other cultures, but in different contexts.
Right. And just following up, last question on that, on the question of dualism, since you are the expert in Kuwait in the Gulf, what's the
Yeah.
difference between a biopsychosocial approach and the dualism view to the world?
I would want your input too. I
Sure.
understand the biopsychosocial approach as an approach to psychiatry that is comprehensive and inclusive of all of these factors. It doesn't necessarily state what your center is, what your um, uh, ultimate determinant is. And I think a neurocentric approach adds that dimension to the biopsychosocial approach. I don't think the biopsychosocial approach is necessarily dualistic or monistic. I don't think it necessarily declares itself as such. It just emphasizes that there are psychological determinants and social or psychosocial determinants to people's mental experiences. And I think that's fair to that is a factually true position. I think being agnostic to whether you're dualistic or not. What I mean, I'm curious
I
what you think
think
as well.
I'd agree strongly to that. I think in a way you can think about it in two ways. I think we either don't include it in the biopsychosocial approach as much as we should, and we don't include our spiritual purposes. Um, and there's a lot of Muslim scholars or Muslim psychiatrists that would say the same, that this should be included and that this is very much a Western view, and religion, especially in the Middle East, is such a central role to this. Um, on the other hand, because I think a big part of dualism in the GCC confirms to our cultural and religious views in particular. And I'm not sure if that's a good thing or a bad thing, but there's an integrated link there. I find.
Yeah, I mean, I don't necessarily think there's a direct relationship between
Mhm.
how I don't think dualism necessarily flows from a religious background. It's just it's a universal experience, and
Excellent.
people of all creeds feel the presence of what we call agenticity, the presence of an agent of me, and um, and I think religion has a positive role to play here
Yeah.
in
And I know in
yeah,
your article, you've said that as well. Like the religiosity actually might correlate
right,
with positive attitudes, or at least it does not correlate with negative attitudes.
right.
But the supernatural beliefs did.
Yeah, I mean, the only relationship, I put the slide back up. The only relationship that we found, there tended to be a relationship between religiosity and belief in the supernatural,
Yeah,
it makes sense. I mean, I
yeah,
believe in some of this stuff. Um, it's part of if it's part of your religion, but it doesn't necessarily. It is not. There's no arrow here that leads to stigma.
yes.
The arrow statistically shown to flow from a dualistic view of the human mind, which is not necessarily a religious concept. Yeah,
So I think what I was trying to say is, and apologies if I miscommunicated this. I think that the biopsychosocial approach needs to address our religiosity a little bit better, and our supernatural beliefs in this culture, and thus connects to mind-body dualism, but not they're not directly linked
yeah.
as that's become clear. Yeah.
You know, I think some work was done by my colleagues in Dr. Fatin Zibin, along with Dr. Harold Koenig from Duke, and a bunch of other researchers showed associations between coping in different medical illnesses and your religiosity. We have a validated, the scale that we used in our study was the BIAC scale developed by Harold Koenig and partly with Fatin, I think. So this is an active area of research, and I think in the world, this place is the place to, or our region is the place to study these phenomena in depth. And these are fascinating discussions, I think. And I think I want to reiterate that, you know, we remain respectful to the cultural beliefs of our that we share. So, yeah.
Right. Moving on from dualism just for a second.
Sure.
I think people are asking about free will as a subject of debate. And do you believe in free will? And what's your stance on that? I know I've got my thoughts about that, and I wonder about yours.
Can you indulge me and give me your thoughts? I'm no expert on free will, and it's it's as old as Earth. So I don't think we're going to resolve it today. So you tell me what you think.
I mean, I know that there's a question, many neuroscientists have asked this before, and there's a lot of debate about with philosophy, and hence this is a really good question for this webinar. There's two views of it, of course. A pure neuroscientist view can say free will is established in the brain, and that you can predict your choices about maybe about half a second before you actually choose to do it. And so we can acknowledge that some of the chemicals, and those are studies being taken from, I think, simple tasks that we have, but we can say that you'll move your hand before you actually move it, or before you decide to move it, when clicking yes or no, or things like that. So these are interesting questions. I think from a religious perspective, those questions are intriguing. I'm not a religious expert, and I will not touch that perspective, but I think the free will there is something that is that we are different from other animals, or there's an evolutionary perspective as well, that we're different from other animals, or different from other regions, that we have free will, and that's really what establishes the difference between humans and other animals, or animals in general, and that's another question. I'm actually willing to open this up to the floor as well, if anyone
Absolutely.
has any other thoughts.
That would be great.
Yeah.
If people can raise their hands and weigh in, that would be amazing. I would love to hear from people. Dr. Abdullah, you can tell me if you have someone who wants to chip in. And I can tell you that I can tell you what I sort of I thought about this a little bit, and you know, I think the question comes down to what you mean by free. If people mean by free that it magical, and then I think the answer is, I personally think that there's no magical supernatural free will. In other words, if I have a right-sided stroke, I am never going to be able to move my left body instantaneously unless something happens in my brain. So I think that's pretty easy to agree on. And then there's the gray area of difficult things, like resisting eating something, or you know, moral decisions and so on. And I think those have determinants in the brain, but there's a wide range of outcomes that can You know, there's a neurological process that happens that leads to the outcome, and it's got determinants, many of which are subconscious. So all of this argues for determinism, not for free will. But if you think that, you know, this is an equation and it's got potential answers, and the answers are many and they depend on external factors, so this sort of creates a certain unpredictability that sort of looks like freedom. That, along with the agenticity that the brain creates, I think argues for the presence of a grounded free will. At least, you know, you could say there's a will for sure. And I think that would be my approach and view to it, and it doesn't trouble me, because the concept of free will in the magical sense is just, you know, it just doesn't make sense.
Yeah.
In today's age.
Haytham, I'm wondering, there's a few people that have raised their hand. Sorry, Haytham, if it's okay, Mustafa, can we share some of, or open their mics for some of these people who have raised their hands?
Yeah, sure.
Wala, Dr. Wala or Dr. Khadija or Dr. Muhammad al-Najm or Muhammad al-Dardiri. Dr. Wala, I think you're permitted to talk if you want to unmute your mic, if there's something going on.
Is it working?
No, I'm not sure. Or
yeah,
I think Dr. Khadija, you can unmute your mic. Dr. Muhammad al-Najm.
Hi.
Hi. Great.
Muhammad al-Najm.
Al-Najm, sorry, apologies. Okay.
I think this discussion is complicated to have, because what does it mean to have free will? Does it mean every manageable behavior that you think you can do and you want to do, you'll do it? Or you'll do every manageable behavior you want to do?
Mm-hmm.
Like, if I want to, okay, I want to start running, I can run. Is that free will, in your opinion?
You're right. I think those are interesting thoughts. It's about even sometimes your free will is that you choose not to do something, of course.
Yeah.
Right? And
Yeah. I mean,
yes.
Okay, there is right and wrong always, and good and evil.
Mm-hmm.
Okay, so sometimes you would choose to, you want to do the right thing, but you choose the wrong thing. For example, eating unhealthy foods rather than eating healthy. You are not in control of your needs, or what do you want, what your mind wants. Especially the biological needs, like food and sex. There are needs. It kind of controls you. You're a puppet to them. For example, if you're angry, you can't really control your behavior. The anger is imposition of your conscience, in a sense. So
Dr. Muhammad, I think that's it. Thank you for your take on that. I think you raise an excellent point about sometimes our drives are not always listened to or adapted properly, and I think sometimes our choices don't always obey our drives or what we want. For example, hunger is a very clearly biological drive,
Need.
and yes, and sometimes we eat, and sometimes we move on to do something else, and those are, it's not just a decision, but also where to go from that. So thank you. That's a very, very interesting take. I wonder, Dr. Haytham, do you have a?
Yeah, I mean, I would, you know what I'm thinking. First of all, thank you for the comment. You know, articulating these thoughts is not it's not easy. So I really thank Dr. Muhammad for coming forward and expressing his opinion. And I really hope, you know, I wish I gave this course in Dar al-Hikmah University here in Jeddah. And we sort of had debates like this with the students over there all the time. And this topic sort of sparks interest like this. And if you look at the biology, you know, we think of our desires and of our, you know, so things like sleep, food, reproduction as obligatory and bottom-up phenomena. But these are also controlled by, or let's say modulated, not necessarily controlled by top-down mechanisms. You know, we were discussing the role of the dorsomedial prefrontal cortex in modulating food intake, for example. And it turns out, and it was shown in studies, that the dorsomedial prefrontal cortex is a part of your brain that stops you from eating the big chocolate cake that you are looking at. But then it's also the part that makes you feel guilty after eating it. So there's deliberation. This deliberation that happens, that we experience, which is based on brain mechanisms, is, I think, the closest we can get to the concept of free will, or of will and volition. You know, feeling like a puppet is not exactly a great feeling, right? If you feel that you're just a machine, it's not a great feeling. And I think, I sort of think yes, the human mind is a machine, the human brain is a machine, but it's so complex and it's so powerful, and it's got a wide range of capacities and things to do, that it's got illusion, at least the illusion of freedom. I rarely argue for free will, but I think. But I think I also don't want to leave people with the feeling that you're disempowered by your brain. You're actually, you are your brain, and you're empowered by your brain. And I think the deliberative processes that happen in the cortex are somewhat the closest that we can get to a reasonable perception of freedom in our behavior, I think.
Great.
Well, one additional point is, in the clinical context, if you talk about that lady with depression, in that sense, it doesn't make any sense to say that she has free will that should overcome her depression, right? Or that person with OCD that wants to insult the divine, then there's zero free will there. That is a completely cerebrally determined process. And just like Dr. Abdullah, you said, that sometimes there's a free won't. That sometimes he's able to suppress his compulsion. This is a fascinating discussion. I'm clearly enjoying this, so please feel free to stop me.
Great. I'd like to take some from other other people. Dr. Mohammed Al-Dardiri, do you have anything to say? You can unmute yourself at this point. And then, yeah.
Hello, good evening.
Good evening.
You can hear me, okay. Well, first of all, thank you. That was one of the best lectures I have ever attended. Me too, I am enjoying it. The esteemed speaker has done a great job, and also, and of course, also the esteemed chairman. From my side, I don't believe in free will, simply. Before talking about free will, you have to exclude first our past experience, our hormonal load, our full biological architecture, and then after that, after excluding all that, I don't think you will have anything left. So we can call all the sum of all that our free will, if we want, just to save our ego. But I still don't believe in free will. My question was spirituality. We know from evidence that spirituality actually do help for some, for those, at least for those who believe in, have a belief system. Would you recommend, would you actively recommend spirituality for someone, I mean, just out of the blue? Would you actively recommend it? That's my question. And okay, that's it for now.
Dr. Abdullah, do you want to go first? Do you want me to go first? You're the boss.
If you've got something, if you've got your...
I'll quickly say yes. I do. I would. And full stop. A period. I do. I recommend spirituality. Of course, I want to make sure that people are taking the right, the pragmatic actions that need to be taken to taking their medications, doing their therapy, and so on and so forth. But spirituality is just like the doctor said. Yes, it is. It's got demonstrated benefits, and it does not contradict anything we said. Spirituality is also neurobiological. It also works at the neurobiological level.
I think that would be an interesting talk all in itself.
Yes, maybe one other day. Yes.
I think I've also done some research on that. Never published it, unfortunately, but it was my master's project. Well, it's published as a master's project about spirituality and mental health or burnout and professionals and us. And it's just interesting as we approach the coronavirus, and we've run a telepsychiatry service, that we've seen how spirituality is so helpful, and we know the evidence is there that it helps coping and it helps that perspective. The thing that I'm always cautious about as a psychiatrist is sometimes some religious practitioners are overselling spirituality as a treatment, for example, for epilepsy or for neuropsychiatric disorders, and that's always a worry as well. And so I would very much, and I have very much said, spirituality is a really good thing, that we should encourage it, but that, like anything else, it's not a treatment for everything. And yeah, I think if we can move on to the next hand raised, please. There's quite a few hands and there's quite a few questions, and I'd like to give everyone a chance. I'm really enjoying this discussion. I really am.
Me too. I am really grateful to everybody. That's I'm learning from everybody. So that's great.
And they're making us think, which is great.
Yeah.
Especially during the Corona times.
I know.
Mustafa, can you...
Such tough discussions too.
Yeah.
I see that there's Dr. Abdullah, there's a few, there's a long list of open questions.
Absolutely.
I'm not sure.
Let's try to approach those as we're, as Mustafa does the hands. And I think there's questions about free will, and that might be another thing for another day. It's one question is really interesting about what about the subconscious, what about the topic of free will? And people are all agreeing about spirituality as another webinar as well, Haytham. So you're probably in much demand very soon.
Well, you're the expert. You just declared yourself. You're up.
I have not declared. I'll happily try to take that on if you help me as well.
Yes.
Yes. there's more questions. There's one question is we've talked kind of about is there's no defined biological basis for a moment of consciousness, like Descartes has said, when he said when I think I am, or he says when the person says I am. I'm not sure, and again it comes up again, a biological basis of consciousness. What are your views on that?
Hi. First of all,
Hey.
I'm not a neurology resident. I'm specializing in internal medicine, but I have a special interest in neurobiology and human behavior.
What's your name, doctor?
My name is Najwa Al-Mahfoud. I'm from Saudi and I'm specializing currently in internal medicine. But I have a special interest in psychology, neurology in general, and I'm seriously thinking subspecializing in it in the future. So first of all, I want to ask I want to thank Dr. Hatem for this interesting webinar. It's really thought-provoking. And I would like to ask him if he's ever come across psychoanalysis, because my questions are specifically with regards to this field.
Yes, let me just, before you ask your question, I am a spectator. You have a full-fledged psychiatrist sitting right 2 boxes from me. You can direct all your psychoanalytic questions to him.
Perfect.
And one day, perhaps we can also involve, we have the region's only handful of certified psychoanalysts. I would love, I know them in my head. I don't want to impose on them, but I'll certainly approach them. But please ask your question. They're not here, so they're not going to judge us. They will never judge us.
Sure.
They're really awesome people. Go ahead, please. And it's nice to meet you.
Nice to meet you too. So my question is about Jungian analysis and the shadow work. Again, I'm not sure if you've come across this term before, but to give like a brief explanation of it, like from my humble experience, it's like coming to term with the suppressed emotions or feelings of, for example, experiences that were not dealt with from childhood. So my thought on this was like from a personal experience, whether psychoanalysis is superior to cognitive behavioral therapy and the management of certain mental disorders. Like, in terms of coming to term with suppressed emotions and being and becoming a whole being instead of somebody with like split personality or disintegrated self. I don't know what's the term for it, but the main purpose of the shadow work is to become a whole person, and by becoming a whole person, you basically disidentify with your mind. So all the thoughts that previously would have led to depression would basically have no effect whatsoever on the self, and so the human being themselves become free of the control of the mind. So my thoughts are on this particular mode of management and whether it's somehow superior to the cognitive behavioral therapy that is nowadays widely used. And my second part of my question is about, again, is complementary to the first part. It's about the levels of consciousness. I've read a few books about spirituality and healing and stuff, and personally I've been using them myself, and they have really great effects on my well-being in general while working in patients. I've experienced a great compassion, and I have been able to connect more with my patients. And so again, I think this area deserves a great deal of research. And I'm not again an expert or something, but it's just an opinion that I think this area in particular is not really well covered so far. And I think from my humble experience that some doctors don't really give it a great attention when managing their patients. And I think sometimes some patients are labeled with, for example, depression or anxiety, like just from a conventional point of view. Again, I'm not really undoing that or something. No, I'm not underestimating it. And I'm not saying it's wrong or false. I'm not a psychiatrist, but I mean that I think a holistic view of the person themselves is deserving of attention, because sometimes this can change a lot of things in both the diagnosis and the management. Yeah, it's a long topic, and I'm not sure if I delivered my thought clearly, but I would like to hear from anybody who has come across this field before.
Sure. So I'll tackle this. I think it's an interesting question, particularly because we were talking about duality, and this is a different kind of duality, right? So it's between what we call, so the shadow self is from, as you said, the Jungian theory, but it's a little bit like yin and yang, or light and dark. In fact, that's what there's a dark self in all of us, and what is the shadow self is kind of that dark self. And sometimes we react, we've all had this, where we react in moments where it's not kind of who we think we are, or against our own nature in a way. So maybe you've thought a time when you flew off the handle at someone for no real justifiable reason, or that was just, you did something that was out of character for you. And the shadow self is kind of controlling you, either with envy or jealousy or rage or lust or desire for power or other things like that. So it's a different kind of duality than the one Haytham brought up today, but all the more reason to think about it in kind of philosophical terms. I think psychoanalysis is not dismissed, but I do think CBT is faster and works quicker for most of the problems that are in the here and now. I think psychoanalysis and things like that are really helpful. In fact, I'm happy to share that I've done 3 years of psychoanalysis or psychodynamic psychotherapy, not really psychoanalysis light. And that was essential, I agree, to how I cope and how much empathy I can give, even when I'm drained and when I'm not 100%. I think it makes me a much better psychiatrist, a much better doctor, and I hope a much better person as well. And so I do think there's a lot to say about psychoanalysis. It's just because it takes a few years, it's much harder to do the studies, and it's much longer in time. So that's another thing. I do want to move on to the next. I hope that's answered some of your questions. I do want to move on to the next question as well, just because there's quite a few people that have raised their hands. I also want to make sure that we reach Dr. Ru'a, who has raised her hand and is another neuropsychiatrist as well, or a behavioral neurologist, apologies. And I just want to make sure that we address her before we leave.
Yeah, hello.
Hello.
Yeah, hi. This is Mohammed Al Hashmi from Kuwait. First of all, thank you, Dr. Abdullah and Dr. Tayyib, for this amazing opportunity. Earlier on in the lecture, Dr. Tayyib mentioned that some patients with mental illness would actually start blaming themselves for psychiatric symptoms. And that's not the only point that I think that I've come across throughout my career. I think some patients do tend to blame also the physicians for psychiatric symptoms or mental illness. In these instances, how would you recommend physicians to actually act, because some patients will be in denial, and nevertheless, besides the denial, they actually start to be aggressive towards the neurologist or the internist that actually tells them that whatever symptom they have is actually non-organic.
It sounds like these sound like difficult situations. I personally, and I'm not sure, I'm going to answer the question indirectly. I personally use neurobehavioral counseling in my clinic all the time, meaning that I always try to tell patients what they have in brain terms. So if they have a panic attack, that's the easiest thing to describe, right? So I'll tell them that there are specific regions in the brain that control fear. I'll describe what fear is, what its functions are, what the amygdala system is, what the mesial temporal does. And I'll tell them that theirs is not functioning properly. I personally find, and I think this is still to be shown, I personally find that describing things in organic terms helps, provided that you don't dismiss the remainder of the picture, because that can get you in trouble. You know, your work is much harder than my work. Whenever I get in trouble, I say, well, I'm a neurologist, I have nothing to do with this. And I can raise my hands and shrug my shoulder and say, it's none of my business. But doing psychiatry is I think of it as a privilege. But it's also, it's tough work. And you know, I don't think I have answers to what Dr. Muhammad, you asked me. But if I can add something, I will say that using brain terms, I found that using brain terms helps. I don't know what Dr. Abdullah's experience is.
So Muhammad is a neurology resident. And I'm guessing he has some.
His work is still hard.
Yes, absolutely.
Not as hard as yours.
I think he has questions about that. When we've talked previously about things like this, it's about psychogenic disorders and whatnot.
Oh, I see.
So poly or PNES. And so,
right. So even that, in that case specifically, actually, I try to use whatever neurobiology we know, and try to describe it in brain terms. Because I find that when you tell patients that you have fake seizures, for example, or that you're faking your weakness, it always backfires. People understand, I think, perhaps it's been my observation that people understand it here more than in the West, perhaps, that your psychological state does have something to do with your body state. But that's not the part that usually bothers people. What bothers people is the implicating them or implying that they are faking their symptoms. So definitely that's something that needs to be avoided. People with psychogenic seizures are not faking their symptoms, and their symptoms are determined and are, for the most part, involuntary. It is rare that you can prove that someone is malingering or trying to fake it or something like that. So I think that would be my position, and that's the position I take in the vast majority of all the time, I would say.
Thank you.
Yeah.
I'd agree. I'd strongly agree with that, and I think I actually suggest sometimes that there's some fMRI evidence about conversion, that this is not just all in your head or anything like that, that we can see it sometimes in some of the scans, etc. And sometimes that helps as well, raising that biological perspective as well. I'd like to move to Dr. Roa. It's a pleasure having you here, and I'm wondering if I know you've raised your hand. I'm wondering if you have anything to add or.
Hi, good evening. Do you hear me?
Hi. Yes, we can hear you.
Well,
yes,
thank you very much. It's a very, very interesting discussion, very interesting talk, and thank you for kicking start these webinars. My comment is about the relation between psychiatry and neurology and how we're being more related, and how our understanding of the brain, the more we understand the brain and the more we understand these disorders, the more we find how psychiatry and neurology are very related. We now know, for example, that for years we've been saying that people with bipolar can develop Parkinson's secondary to the antipsychotics, but now we know that it's not only the antipsychotics, and we think of bipolar as probably a prodromer of Parkinson's disease. The C9ORF, for example, behavioral variant FTD, and how a prodromal of psychiatric illness can precede the behavioral, the frank behavioral variant FTD. So many studies have shown how neuropsychiatric symptoms can precede cognitive decline in dementia, for example. Even what's very interesting are the change in our understanding of functional movement disorders and functional neurological disorders, and how, as you've mentioned, as you mentioned, Dr. Abdullah, about convergent, it's not in your brain, it's not in your head, it's in your brain, and how there are evidence that functional disorders are not only functional, they are truly organic brain disorders, and how the change of understanding, how when we understand things differently, we tackle them differently, and then we treat them differently. And how when you believe that the functional disorder of this patient is a true organic disease and you start taking it seriously, how the outcome can change. And I find this very, very interesting. I find the jumps that we've taken recently in our understanding of the human brain is very interesting, and I'd like to hear from you.
So, Haytham, do you want to respond?
I want to express how delighted I am to hear Dr. Rua's comment. It was like poetry to me. I love it, every single word of it, and man, there's nothing to add to that. I really love it. Psychiatry and neurology were originally one field. Now it's still one field. We're still one big happy family most of the time, and I think there's a lot to learn from each other and work together. And Dr. Roa, you should be up next on the webinar series.
Inshallah.
I look forward to, hearing your
you just
talk.
made it difficult by tonight's talk.
No,
I should work harder.
I look forward to your talk. I will.
Thank you.
I really do. Thank you so much for your comment. I loved it.
Thank you. Thanks a lot.
Again, so Dr. Roa, thank you so much for contributing to this. I'm also very aware of the time, but I think you've raised some essential questions, like especially with the new meta-analysis last year about Parkinson's disease and bipolar disorder, and that there's about a 3 times risk or a 2.5 times risk with bipolar. I'm actually never sure, is it the medications or is it the bipolar itself that's contributing to this, and essentially really interesting topics about how we're integrating back again between psychiatry and neurology, and that we need to address some of these. There's even a question by a psychiatrist, I think, was asking about, do our programs in the Gulf have a deficiency in neurology, and psychiatry residencies have a deficiency in neurology, because in Egypt they have about a 2-year schedule of neurology where they do 2 years of neurology before finishing their boards. I know in the US and Canada and the USA and the Western world, that's they don't do, or we didn't do 2 years of that, but it really is an essential component of how we understand things, and maybe that should be more of a focus in our training on both sides. And I think that really is the highlight of these webinars. So I really appreciate your comments. And I think at least for now, we'll talk about the future as hopefully that maybe this is both an integrated field altogether. I see. I think we're going to take one more question, and then because I noticed we're past our time as well.
Good evening,
Dr. Wala, or yes, go on. Sorry. Good evening.
Hi. Good evening. I'm not doctor yet. I'm a medical student, a fifth-year medical student, so from Arabian Gulf University. And this is my pleasure to take part in this talk. And I'd like to thank you both doctors and all the people who participate and discuss some of their questions. So, and I'd like to apologize first of all for going back on the topic about the free will. But I have a question. A believer to some extent that we all have a free will, and depending on our hormones and all those kind of parts, we have some control over it. My question is, when do patients or people or mentally ill patients, for example, a patient with depression, will regain their free will? And if they do so, how does it work with the behavioral therapy? So this is it. This is my question. So what is the importance of how can we manipulate or how can we help people to regain their free will with the behavioral therapy? And if we can do so. Thank you.
I think I can quickly say something about this. Yeah, I think therapy empowers people in its various kinds. This is obviously therapy is not one thing. There's different schools of therapy, different modes of therapy, different indications, and so on and so forth. But the bigger question is, if the concept of again, it comes down to the definition of free will. If you say it's free, then it can't be disordered. Free means it means free of everything. So I think we can toss that concept away. And if we keep the concept of empowerment of people with psychiatric disorders, then, you see this over and over. Psychiatry empowers people to overcome psychosocial stressors and overcome their biological disorders. So I think there are a lot of specifics depending on what context you're talking about, but I think that, but generally, yes, therapy empowers people. And you can actually see that in the study I showed. One small point that I didn't tackle was that you can tell by fMRI, some studies were done to sort of, they showed that you can tell which patients will respond to therapy or not, depending on what their fMRI activation pattern is. And when you see cortical activation, then it means therapy is going to be your it helps you become eclectic in how you choose your mode of therapy. Long discussions. We should have a lot of these webinars to address all of these awesome points. Yeah. Dr. Abdullah, your mic is muted. You might want to unmute. Yeah.
Sorry, apologies. I think the last question the last person will allow for today is Dr. Lujain Khoja. Maybe I know you might have something to say, so
okay,
please.
I'll try to wrap up since everyone is really like 1.5 hours. At first, I'd like to thank you all. Thank you, Dr. Haytham. Thank you, Dr. Abdullah. This was an amazing presentation for neuropsychiatry in the region, and I hope we will continue in having this kind of lectures and activities. What I wanted to add on is there was 2 questions about delivering the diagnosis of functional symptoms.
Doctora, so sorry. Can you raise your voice just a little bit? I am having a hard time hearing you. And everyone should know that you've studied neuropsychiatry, and you're a nearly blooming, full-blown neuropsychiatrist.
Thank you.
But raise your voice a little bit just so I can hear the question.
Yeah, sure. Thank you for letting me know. Is it now more clear than before?
Yes.
Okay. So my name is Lujain Khaja. As Dr. Haytham said, I have a degree in neuropsychiatry from King's College London, and I am doing now a psychiatry residency program in Jeddah. So, and my thesis was about functional symptoms. That is when the symptoms has no organic reason in any kind of test, lab results, or radiological study. And what I wanted to point out is that when we are delivering the diagnosis in the right way, the outcome of these patients is better. So it's better to have like another way of telling the patient that your symptoms is all in the mind, but we have like another way of delivering this diagnosis. And I really wanted to share it with you. When we are telling the patient your body is like a computer, every part in that computer is working well, but the software is not working well. There is something in the function, but not in the organ. And there is a paper published on delivering the diagnosis by this way, and it showed how the patient accepting their diagnosis and how they are having a better outcome. This was raised, I believe, by Dr. Muhammad or Dr. Abdullah, the question just before this one. And I wanted to share with you this kind of terms to use it with the patient. I saw how it makes a difference in the patient when I was in London. So maybe we can use that in here. And thank you for all the information you provided. It was awesome to attend this lecture.
Thank you so much. I know you personally. I know your passion, and we have a project together. I endorse everything you said. The computer analogy is something that's very commonly used. If used in the right way, I think it can be very, very helpful. I think, we also need another talk for, or talks for functional disorders. Unfortunately, the flip side is when these people are not dealt with properly. They're tossed between professionals. They're not explained their diagnosis or their condition in a productive manner, and it all backfires. These people end up receiving no help. And psychogenic seizures, for example, are just as disabling as epileptic seizures in some situations. So yes, I think we should definitely, maybe Dr. Lujain, you can give the talk on functional disorders one day in this webinar series or in this collective conversation that we're having here.
Great, just a couple of more questions. Sorry, respondent, please go ahead. It says you're a neuropsychiatry webinar participant, so apologies, I don't know your name. Hello.
ايوه
من الدكتور احمد.
ايوه دكتور احمد معاك. ايوه اهلا وسهلا.
السلام عليكم، تفضل دكتور احمد.
معلش انا يمكن مش هعرف اتكلم الانجليزي زيكم، انا بس عندي شكر الاول وتعليق. الاول بشكر الدكتور هيثم، انا عجبتني طبعا المحاضره. انا الاول اسمي احمد عيد، شغال في السعوديه هنا، وانا من مصر مستشفى عباسيه. بشكر الدكتور هيثم، انا عجبتني طبعا المحاضره والتعليقات اللي اتكتبت. شفت المقاله بتاعت حضرتك ولحقت بصيت عليها بسرعه. انا بس ليا تعليق صغير من خبرتي. انا من المدرسه القديمه بتاعت النيورولوجي والسايكاتري مع بعض، يعني كومبايند سواء تريننج او براكتس. يعني انا اشتغلت في ستروك يونتس وفي اي سي يو سليب لابس وبلازما فاريسيس، زي بالظبط ما اشتغلت في الاي سي تي والتشايلد سايكاتري وال12 ستيبس بتاعت الجروب بتاعت الادكشن. فاحنا في مجموعه في مصر بعض كليات الطب القديمه اللي هي اشتغلت نيورولوجي وسايكاتري كومبايند. وده واضح زي فرويد، زي ما حضرتك قلت. يعني فرويد نشر حاجات في النيورو ماسكولار ديس اوردر وهو اتدرب كنيورولوجيست، ويونج نفس الشيء، وفي دكاتره كتير النهارده كده. حتى في كندا في واحد اسمه جيرب نورتوف، ليه يعني كتب كتير في النيورو سايكو اناليسيس. انا بس عايز اقول حاجه تاريخيه نستفيد بيها. تاريخيا السايكو اناليست كانوا هم الامبرياليست والمتحكمين في كل حاجه لغايه السبعينات، وكان الدكاتره البيولوجيست سايكاتريست عشان يدخلوا دواء السوق ولا عشان يعتمدوا دواء لازم ياخدوا موافقه السايكو اناليست ان الدواء دوت بيحسن الايجو او بيأثر على الديفنس ميكانيزم او بيحسن السب كونشس او كده. انا خايف ان احنا نكون في العصر المضاد دلوقتي ان البيولوجي هو الامبرياليست وان اي حد هيعمل اي حاجه لازم ياخد اعتراف البيولوجيست وياخد اعتراف الاف ام ار اي، عايز يعمل سي بي تي، عايز يعمل جروب او كده. واقعيا الانكونشس اللي وصفه فرويد اتوصف بكذا طريقه بعد كده. يعني انا ليا قراءات كتير مع فرويد، وفرويد لو قريت له طبعا الترجمات الانجليزي هي مش صعبه قوي لان طبعا فرويد كان بيتكلم بلغه ثانيه ولما اترجمت بقت سهله. فرويد الانكونشس اللي وصفه اتقال بعد كده بكذا طريقه، هو نفسه الامبليسيت ميموري، هو نفسه الاوتوماتيك ثوتس بتاعت السي بي تي. يعني احنا بنتكلم على امبليسيت برين او سب كورتيكال برين بالمعنى الحديث، زي ما اتوصف في الديمنشا في حاجات كورتيكال وسب كورتيكال، والناس الكورتيكال مش بتروح منهم الامبليسيت سكيلز او السب كورتيكال سكيلز. فاحنا في الاخر عندنا جزء السبجكتيفيتي هو ده اللي طلعنا بيه من فرويد. يعني فرويد لو علمنا حاجه ما علمناش السايكو اناليسيس، لان هو فرويد لما تقرا له قال لك انا بعلمكم السايكو اناليسيس كوسيله اللي انت تفهم الانكونشس. فالانكونشس مايند ايا كان اسمه، سواء حاجه امبليسيت او حاجه اوتوماتيك، هو حاجه كلنا يعني لامسينها وشايفينها، وعندنا امراض بتعبر عنها زي الابيليبسي. بنشوف ازاي الابيليبسي لما تيجي الاوتوماتيك سيجر والاوتوماتيزم، وازاي الاوتوماتيزم ممكن يطلع بحاجات يعني هيدن وحاجات غريبه. يعني انا في العباسيه في قسم الفورنسيك عندنا شفنا جزار مثلا الاوتوماتيك بيهيفير بتاعه ديورنج ابيليبسي كان اللي هو ذبح طفل، تمام. فهنا نفس الشيء، فاحنا برضك عندنا حاجات في السايكاتري بتطلع بنفس الطريقه بس ليها كورليت مختلف. فانا خايف ان احنا نكون في العصر بتاع النيوروبيولوجي هو الامبرياليست هو المتحكم، في حين ان الحاجات دي عباره عن كورليت، والكورليت ده قد يكون ثابت او مش ثابت، زي ما بنشوف السايكوزز في امراض كتير ونشوف في الديليريوم ونشوف
دكتور. I think just to interrupt you, I think the point وصلت. I think you're absolutely right about that a lot of these measures are indirect, as we've mentioned before, and where they are oftentimes correlates. Unfortunately, they're the best correlates we have. But you're right, they're absolutely, I think Dr. Haytham and I both
لازم اشكركم. يعني شكرا يا دكتور هيثم، شكرا ليك يا دكتور عبد الله.
الله يخليك. I think we both agree that this is.
Yeah, I agree. And one must remain balanced and humble and cognizant of the limitations.
Yeah, thank you. If I think we'll take questions from the other people as well. There's 3 people that have raised their hands: Dr. Sami maybe, or Dr. Shinakris. I'm sorry if I know I'm saying this wrong, but can you unmute yourself? Hello.
السلام عليكم.
وعليكم السلام ورحمة الله. تفضل تعرفنا بنفسك دكتور.
علي صنبا, psychiatry resident.
Excellent.
Okay. I have one simple question. As we have limitation في العالم العربي, as Dr. Haytham said, the work is not a one-man show. It's a team effort. We need neuroscientists, psychologists, and psychiatrists and neurologists. But in every area here, it's kind of we have limited facilities and limited staff. So instead of approaching the neurophysiology or the pathophysiology for diseases in a molecular and cellular level, can we go the other way around and study the behavior and aim to know more about the diseases? Because for the last 15 years or 50 years, we tried to bring the behavior into the lab to understand more, and we did a lot. But now we kind of lost a lot of the curiosity and the drive among physicians to understand more about psychiatric diseases and neurology. As it is all clear and obvious that we know the neurotransmitters and the anatomical areas. So nobody asked that kind of deep questions, and if we ask them, we cannot answer them with our facilities. So if we go to study the behavior of the patient between relapses or normal behavior before even the patient become a regular or a chronic patient, would it help to understand more about the diseases? Thank you.
Dr. Abdullah, do you want to take this
so
one?
I do think, sure. I do think that's important. I think that when we're looking at behaviors, that's important as well. I think the evidence is that would be nice to integrate modalities and not just behaviors, but there's still a lot to do in our parts of the region as well. And I think cross-sectional, especially if it's prospective studies of behaviors, then that's really helpful. Cross-sectional, not as helpful, of course, but prospective studies of behavior would be wonderful. I totally agree with that. Let's move on to the next question, if that's okay. Dr. Sami Al-Faifi or Dr. Shunekris, you can unmute yourself. Okay. دكتور تفضل. دكتور. Hello.
Hi.
Hi, how are you?
Thank you. I'm good. Can you hear me?
Yes, we can hear you. It's a little bit quieter, so if you can come closer to the mic.
Yeah, now?
Yeah.
Yeah, thank you. First of all, thank you for the lecture. My name is Ashwag. I'm a psychiatrist resident in Abha, Kingdom of Saudi Arabia. I'm really interested in neurology. I have two questions. One is sort of philosophy more than a scientific. I asked it in the chat, the group chat, about the timing. I really want to hear about your philosophy of time and timing of these illnesses. Like we know time, place is an important thing to think about. So the place, we know it is the body and the brain as a matter, but the time, you said we think before we do anything in a matter of seconds. So I'd like to hear more about that. That's my question. Thank you.
I don't think I quite got the question because there was a lot of interruption. It was something about timing, and then I didn't quite get the rest on my end, Dr. Abdullah.
Same here. I think it was about timing of neurology during the psychiatry residency.
Oh, well, that's like an entire topic that we can invite. There's been a lot of publications on this, actually, how to integrate it from the medical education perspective, how to integrate neurology and psychiatry. I think there are bigger questions about how welcoming both fields are in their general training programs to the other field. And I think these are medical education questions. I mean, perhaps we can thank you for the question, Doctora, and I think we can perhaps invite one of the medical education experts, Dr. Bruce Price, who I trained with, has published a lot on this.
Yeah.
I think he would be willing to come and give us his input. I think the ANP, the American Neuropsychiatric Association, would also be willing to suggest someone that can, and we can sort of make this a joint project even. Such big questions for such small time. So much work for the next webinars. I'm so excited. But I think the answer is I don't know. And I think I personally would have loved to get more psychiatry training earlier in my and I did the usual psychiatry training you get in Canada when you do your neurology residency, which is, I think, a couple of months. I enjoyed it. I learned a lot, but I really learned how to take the psychiatric history and approach and the neurological history, by the way, when I did my neuropsych and behavioral neuro fellowship, because that's when you're really embedded for extended periods of time and exposed to the breadth of the bread and butter of psychiatry. So I think earlier rather than later, but also later when you have a better clinical skill set. I know that's not an answer, but I don't think we have an answer.
Well, I think at this point, I just wanted to thank all participants.
Yes.
We said it was going to be 90 minutes, about 45 minutes for questions. and it's been more than an hour and a bit, more 1 hour 15 minutes. It's really sad to bring this to a close. I do apologize. I do want to thank Dr. Haytham and everyone else on this podium, and you really have been a fantastic crowd. Dr. Haytham, you've been a fantastic speaker. We definitely want you back again to talk about some of these topics. Excellent. And so thank you all for participating. I really appreciate it.
Yeah, thank you, everybody. Thank you, Dr. Abdullah. This was an awesome discussion that you moderated professionally and with poise and elegance. Thank you, everybody, for enriching the discussion. I learned just as much as I contributed, or maybe even more. And I look forward to the next one. I really, really do. And this is the goal, to cultivate such a community and a conversation, and to have a place that all of us professionals and people interested to come to and collectively work together.
Absolutely. And we'll try to answer some of your questions and answer your questions after this webinar so that it can be uploaded as well later. So thank you all. Really appreciate your support and your time. Thank you.
Perfect. Thank you.
Bye-bye.